So I will request Dr. Chetan Kantharia, who is professor and head of surgical gastro at KEM Hospital, Mumbai, to speak on the indications of surgery and surgical management of corrosive stricture in chronic phase. So over to you, Dr. Chetan, please.
Thank you very much, Dr.
Sorry,
Dash.
just a minute. So before Dr. Chetan starts, Chetan is now heading the surgical gastroenterology department at one of the very prestigious institutions of the country, KEM Hospital, which has produced before him and then after him his trainees who are now working as surgical gastroenterologists in various parts of the country, including with me. And Chetan has, when I posted the message for this theme, he immediately responded and said that I would like to join because I know that he has a fairly large experience with management of corrosive strictures. Welcome, Chetan.
Thank you very much, sir. At the onset, I would like to comment that Dr. Govil gave a very excellent talk. It was indeed a treat to listen to him. So with this, I begin my talk that a successful conservative management of corrosive injury involves prompt recognition and early treatment, as we have seen yesterday. But in spite of this, and whatever Dr. Govil has said, that at times it is not possible to maintain an esophageal lumen, having taken all measures. And if I were to put number, then I would say around 10 to 30% of patients, they present with clinically apparent esophageal stricture requiring surgery. Now coming to indications for surgery, so they are patients who present with long strictures, multiple strictures, tortuous strictures, irregular strictures, and strictures which are refractory to dilatation. So these are the group of patients who would qualify for surgery after they have been attempted. All the maneuvers of endoscopy have been tried on them and they still have a stricture. Now arises a question is, when do we intervene? When do we intervene surgically? So animal studies have shown that peak collagen deposition occurs at the end of 2 weeks and it continues to occur for a very long time. Though scar retraction is seen as early as end of 2nd week, it lasts for almost about 6 months. And the complete fibrosis, it keeps on evolving until 6 to 12 months after the injury. Hence, if one intervenes very early, when the scar has not been completely formed, there is a very high risk of anastomotic stenosis occurring because of the ongoing fibrosis happening. On the other hand, if we do a delayed surgery, the chance of successful surgical outcome is very high. And hence, everybody does intervene surgically at the end of 6 months after the injury. So this is the minimum period one should wait. That is a minimum of 6 months before you embark upon surgery. So now we have, having decided when to intervene. Now, what organ would you use as a conduit to replace the esophagus? So we have 3 options: the stomach, the jejunum, and the colon. So let us see the merits and demerits of each. The stomach, it stands the risk of having a long-term gastroesophageal reflux with acid refluxing, which leads to ulceration and ultimately stenosis. Besides this, it is also associated with progressive dysfunctional propulsion occurring. And it is not very uncommon to come across a situation when the stomach may not reach up to the neck, to the cervical region. So hence, generally, one does not use stomach as the conduit for esophageal replacement. As far as jejunum is concerned, the blood vessels of jejunum are very thin and friable, and it gets easily affected by the acid and fragile to the erosion of acid, and hence again jejunum is not used. Having said that, one uses jejunum as a jejunal supercharge, a segment of jejunum, when your esophageal colonic conduits falls short by few centimeters. So coming to colon compared to the jejunum and stomach has a robust blood supply, has an improved somatic growth. It is usually long enough to cover the distance till the cervical region, and it is associated with fewer complications of esophagitis and stricture because of the resistance to acid. And hence, generally everybody uses colon as a conduit for esophageal replacement for corrosive injury. Now comes the question that it's decided that we use a colon. Should we use a right colon or a left colon? Unfortunately, there are no randomized controlled trial comparing right versus left colon. And whatever studies are available in literature coming from the high volume centers show overlapping results, arguing in favor of both. But theoretically, the right colon has a very variable vascular anatomy as compared to the left. Though the right colon has ileocecal valve, which prevents reflux. And the biggest argument in favor of right colon is that if you have used right colon and for some reason the graft gets necrosed or it's not used, then you can always use left colon as a rescue colonic conduit. But having said that, generally all of us use left colon, though I'm very sure there are many who use right colon as well. Now comes the question is, what do you do with the residual esophagus? Should you resect it or should you keep it? And this is a controversial reason because we all know that scarred esophagus has an increased incidence of malignancy. But on the other hand, because of the adhesion and inflammation of the residual esophagus, which occurs following a long time caustic injury, there is a high risk of bleeding and sometimes leading to even mortality following esophagectomy. So generally, one does not resect the residual esophagus and you keep the patient on surveillance and follow up for development of malignancy, if at all it occurs after 30 to 40 years. But having said that, I know of some centers who do go ahead and resect the esophagus in our country as well. Now, so we have decided that we'll use colon, we'll use left colon, we will not remove the residual esophagus. How will you place or how will you transfer this left colonic conduit to the cervical region from the abdomen? So the posterior mediastinal route is out because you are keeping the native esophagus in place and it is very difficult to ablate that esophagus. So the only option is the substernal route or the substernal tunnel which you create. And one generally as a rule or now as a protocol we follow is that we do a partial sternotomy so that the thoracic inlet is wide enough and it does not compress the transposed colon and give rise to stricture or ischemia. So this is how one does a sternotomy and you get a wide opening where you can easily pass in the colonic conduit and do your cervical anastomosis. So now once you have brought the colon above, how do you anastomose it? So you have you can either do a hand-sewn anastomosis end-to-end or end-to-side, whatever is the preference. We usually do an end-to-end cervical esophago-colonic anastomosis, or you can also do a stapled anastomosis as popularized by Oringer, where you make in an opening, introduce a linear stapler, and you staple, and then you close the opening which you have made to introduce the stapler. So this is as far as the proximal anastomosis is concerned. Distally, you will anastomose it to the stomach if the stomach is healthy, or if the stomach is also involved, then and you have done a partial or a complete gastrectomy, then you anastomose it to the loop of jejunum. So this is as far as the surgical technique is concerned. Now, to complete, though the mandate is only corrosive stricture of the esophagus, I will touch upon surgical management of pharyngoesophageal stricture also, because it commonly you come across this situation where the pharynx is also involved. So as Professor Anand Krishnan has divided patients of pharyngoesophageal strictures into 6 groups, I will give you the groups and management of each. So group 1 is where patients have a residual lumen and you can pass in a guide wire. So in this case, you can give these patients a trial of dilatation, and you give a trial long enough, and if they do not respond to surgery, then they should be subjected to cervical esophagocoloplasty. In group 2, there is no demonstrable lumen and you cannot pass the guide wire, and this stricture is in close proximity to the laryngeal inlet, leading to respiratory embarrassment. So these patients, what one does is you do a cervical esophagostomy and you do a retrograde dilatation by passing in a bougie, and you establish the passage so that you get a well-matured tract. And once you a well-established lumen, a matured lumen is made, you go ahead and do esophagocoloplasty distal to the dilated stricture, and the esophagostomy usually closes down on its own. Then the third group is where you have a short segment of pharyngoesophageal stricture because of the granulation tissue or synecdoche. So in this case, you have to take help of your ENT colleagues, and you do excision of granulation and adhesolysis under vision with a direct laryngoscope, and this should be done if necessary more than once. Many a times we have also done laser ablation of this synecdoche, and then once you get to see the lumen, all the synecdoche has been removed, then you dilate the tract to obtain a stable lumen. Grade 4 is a dense, non-dilatable stricture of the pharyngoesophageal junction with a normal distal esophagus for at least 5 centimeter length distal to the pharyngoesophageal stricture. So in this case, you do a cervical esophagostomy, lay open the pharyngoesophageal stricture, thereby exposing healthy pharynx above and a healthy esophagus below. And the large defect which is created is closed with using a myocutaneous flap. Usually you can use either a deltoid flap or a pectoralis major myocutaneous flap. And if there is stricture below the normal esophagus, then you can dilate it at later stage. And if it is not amenable to dilatation after you have given enough trial, you can then subject this patient to esophagocolic bypass after 6 to 8 weeks. And coming to the last 2 groups, that is group 5, whereas there is destruction of the larynx, then you do a permanent tracheostomy, follow it up with pharyngocoloplasty, and then you do a pharyngocolic anastomosis above the stricture, and usually you do a side-to-side anastomosis. Group 6 is where no lumen is detected in the cervical esophageal segment beyond this stricture, including your contrast cannot delineate it, examination cannot delineate it. In this case, you do a trial dissection, neck exploration, see if you can identify the esophagus. It is usually cicatrized and very difficult. But if you are lucky enough, if you get it, you can do a esophagostomy. You do a retrograde dilatation above and below both. And once a mature tract is available or formed, you can do a esophagocoloplasty. But this is very easily said than done. Usually, you do not get the esophagus and no lumen is demonstrable. So in this case, this patient remains on a permanent either feeding gastrostomy or a feeding jejunostomy. And the last part is, what do you do with the corrosive injury of the stomach, either isolated or in conjunction with esophagus? So in this case, depending upon the extent of the involvement, again, there is a classification given by Dr. Anand Krishnan. So if it is proximal is involved, then you can do a partial gastrectomy. And if there is the entire stomach is involved, then you do a complete gastrectomy with either esophagostomy or esophagus is also involved, then you take a loop of colon above and anastomose it to the jejunum below. So thank you very much. As I said, I would keep it very simple and to the point. Thank you.
Yeah, thank you, Dr. Chetan, for this nice talk on the surgical management. I am sure with the audience of dominant surgeons, there will be many questions for you in the discussion session.